Here is the question that should be driving every serious analysis of HIMS and HERS health right now. Did the company pivot away from compounded GLP-1s because it saw a strategic opportunity or because the FDA gave it no choice? The answer to that question changes the entire valuation conversation, and today we are walking through exactly how to find it in the primary documents. We are looking at a curated source compendium for conducting a rigorous public equity analysis of HIMS. This is about 32 primary and secondary sources organized by category, with a suggested reading order that keeps your thesis grounded in what the company actually said, rather than what the press decided was the interesting angle. The first thing we want to highlight is the FDA regulatory arc, because this is where most analyses go wrong. Between September 2025 and April 2026, the FDA moved through four distinct steps: a warning letter specifically to HIMS in September 2025, challenging marketing claims around compounded semaglutide, a February 2026 announcement of intent to take action against non FDA approved GLP-1 drugs, a March 2026 warning to 30 telehealth companies across the sector, and an April 2026 policy clarification for compounders as the national GLP-1 supply began to stabilize. Read those four documents in order, and the story tells itself. The agency was executing a textbook playbook for closing a compounding loophole once the shortage condition it was premised on resolved. The compounded semaglutide revenue stream had a known expiration date in FDA policy. The March 9 strategic shift announcement from HIMS came between the sector wide warning in early March and the policy clarification in early April. Proactive pivot or forced march. The chronology matters. The second point we want to make is about the three-way competitive squeeze that the GLP-1 pivot puts HIMS into. On one side, you have Novo Nordisk and Eli Lilly running their own manufacturer direct patient programs, Lilly Direct and Novo Care, which are essentially designed to disintermediate the telehealth layer. On the other side, you have rising patient acquisition costs and peers like Ro doing the same access play. The central question the primary documents help you answer is whether HIMS becomes a care layer with genuine clinical value add, an access router that captures thin margins, or something that gets squeezed from both directions. The article recommends actually clicking through the Lilly Direct and NovoCare patient flows yourself, because that experience is what HIMS is competing with, and no secondhand description of it is as useful as just going through it. The third point is about the medium term platform bet that tends to get drowned out by GLP-1 noise. HIMS is actively expanding into menopause care, testosterone, peptides, lab testing, and international markets through the Zeva acquisition. The question the compendium frames as the genuinely interesting medium term one is whether those expansion threads collectively justify a multi category subscription consumer health valuation, or whether the brand is structurally a single category men's health franchise, where each adjacent category gets expensive before it gets profitable. The FY 2025 10K is the best single document for assessing that, particularly the segment disclosures and the refreshed risk factors section. The reading order the compendium recommends is to start with the 10K, then the Q4 shareholder letter, then the three GLP-1 pivot announcements in chronological order, then the FDA primary documents in chronological order, and only then to turn to the secondary press. That sequence changes how the Reuters and Barron's pieces read, because by the time you get to them, you already know what the underlying documents actually say. Subscribe to On Healthcare for the full written analysis and deeper podcast episodes on this and other healthcare technology stories. Link is below.